Hello everyone and welcome to the course of General Surgery. Today we're going to talk about hemostasis, disorders of the primary and secondary hemostasis. First of all, let's talk about three key definitions. The first definition is bleeding or hemorrhage is an acute loss of blood from a damaged blood vessel. Second definition is homeostasis is a state of steady internal physical and chemical conditions maintained by living systems, the ability to maintain a relatively stable internal state that persists despite changes in the world outside. Hemostasis is the third definition, is a sequence of events leading to the cessation of bleeding by the formation of a stable fibrin platelet hemostatic plug. It involves interaction between the vascular wall, platelets, and coagulation system. I will remind you about structure of the vessel. The three main layers you must remember. First layer is tunica externa. Second layer is tunica media. Third layer is tunica interna. Also, classification of blood vessels you must remember as well. They divided for arteries, arterioles, capillaries, venules, and veins. Hemostasis occurs in two stages. Primary, when forms a weak platelet plug and is mediated by interaction between platelets and the vessel wall. Secondary, when stabilizes the platelet plug and is mediated by the coagulation cascade. The primary hemostasis occurs in four steps. First step is transient vasoconstriction of damaged vessel mediated by reflex neural stimulation and endothelin release from endothelial cell. Second step is platelet adhesion to the surface of a disrupted vessel. One Willebrand factor binds exposed subendothelial collagen. Platelets bind one Willebrand factor using the glycoprotein 1b, which is located on the surface of the platelets, which facilitate initial platelet adhesion to vascular subendothelium after vascular injury. One Willebrand factor derived from the Weibel blood bodies of endothelial cells and alpha granules of platelets. Third step is platelet degranulation, shape change of the platelets and degranulation with release of multiple mediators. Adenine diphosphate is released from the platelet-dense granules. Promotes exposure of GP2B3A receptor on platelets. Thromboxane A2 is synthesized by platelet cyclooxygenase and released, promotes platelet aggregation. Fourth step is platelet aggregation. Platelet aggregation at the site of injury via GP2B3A using fibrinogen from plasma as a linking molecule results in formation of platelet plug. Platelet plug is weak. Coagulation cascade secondary hemostasis stabilizes it. On this picture you can see the scheme of steps what occurs during primary hemostasis. Disorders of primary hemostasis. When abnormalities occurs in platelets, they can be divided for quantitative and qualitative disorders. Quantitative is when decreases the number of normally functioning platelets, and qualitative disorders is when the problems with structure or function of platelets occurs. Clinical features: mucosal and skin bleeding. Symptoms of mucosal bleeding include epistaxis or nose bleeding, hemoptysis, GI bleeding, hematuria, menorrhagia. Symptoms of skin bleeding include petechia, purpura, ecchymosis. Laboratory studies shows platelet count is decreased when it's lesser than 50 thousandths, it's lead to symptoms. Bleeding time is prolonged if pathology occurs. Bone marrow biopsy shows megakaryocytes because they produce platelets, so it's like a protection reaction of the organisms. If in the organism decreased number of the platelets, of course the organisms will be trying to produce them more. That's why megakaryocytes showed up, and in bone marrow biopsy you can see a lot of megakaryocytes. On this picture you can see clinical features and appearance of the petechia, purpura and ecchymosis. So let's talk now about quantitative disorders of the primary hemostasis. Immune thrombocytopenic purpura, one of them. It's autoimmune production of immunoglobulin G against platelet aggregation, for example GP2B, GP3A. Antibodies are produced by plasma cells in the spleen. Antibody-bound platelets are consumed by splenic macrophages, result in thrombocytopenia. Divided for acute form, arise in children weeks after a viral infection or immunization. Self-limited, resolving within weeks of presentation. Chronic form, arise in adults, usually women of childbearing age, may be primary or secondary, for example due to systemic lupus erythematosus. Laboratory finding shows platelets count is decreased, lesser than 50 thousandths, normal prothrombin and partial thromboplastin time. Coagulation factors are not affected in this pathology. Megakaryocytes on bone marrow biopsy is increased. Treatment is usage of corticosteroids. IV immunoglobulins is used to raise the platelet count in systematic bleeding. Its effect is short-lived. Splenectomy eliminates the primary source of antibody and the site of platelet destruction. On this picture you can see the scheme of treatment of the primary IOTP. First line therapy is corticosteroids, intravenous immune globulin and anti-RHD. Second line treatment is splenectomy and rituximab, and third line treatment is retreat with corticosteroids and other kind of experimental drugs used. Another pathology is microangiopathic hemolytic anemia. It's pathologic formation of platelets microthrombi in small vessels. Platelets consumed in formation of microthrombi, and red blood cells are sheared as they cross microthrombi, and it results in hemolytic anemia with schistocytes, seen in thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. TTP is due to decreased ADAM-TS13, an enzyme that normally cleaves 1 Willebrand factor multimers into smaller monomers for eventual degradation. Large uncleaved multimers leads to abnormal platelet adhesion, resulting in microthrombi. ADAM-TS13 decreased usually due to an acquired autoantibody commonly seen in adult females. HUS is due to endothelial damage by drugs or infection. Escherichia coli dysentery due to exposed undercooked beef is a common reason in childhood. Escherichia coli virotoxin damage endothelial cells resulting in platelet microthrombi. Clinical findings: skin and mucosal bleeding, fever, and renal insufficiency, CNS abnormalities. Renal insufficiency is more common for hemolytic uremic syndrome, and CNS abnormalities is due to thrombotic thrombocytopenic purpura. Laboratory findings shows thrombocytopenia with increased bleeding time. Normal PT-PDT is because coagulation cascade not involved, and increased megakaryocytes on bone marrow biopsy. Treatment is plasmapheresis and corticosteroids. To the secondary causes for microangiopathic hemolytic anemia, we can include such reasons as drug-induced pathologies and due to chemotherapy or cocaine usage, immune-mediated mechanisms. It's due to lupus erythematosus, acute glomerulonephritis, scleroderma, pregnancy and postpartum period, such as HELLP syndrome, hemangiomas, and miscellaneous reasons. And on this picture you can see samples of appearance of the schistocytes. It's damaged, I will show you, it's damaged red blood cells due to microthrombs. Another group of disorders is qualitative platelet disorders of the primary hemostasis. It includes Bernard-Saulnier syndrome due to genetic GP1B deficiency. Platelet aggregation is impaired. Mild thrombopenia with enlarged platelets occurs. Glanzmann thrombocytopenia due to genetic GP2B3A deficiency. Platelet aggregation is impaired. Aspirin is irreversibly inactivates at cyclooxygenase. Lack of thromboxane A2 impairs aggregation. Uremia disrupts platelet function. Both adhesion and aggregation are impaired. And on this picture you can see general appearance of the platelets, erythrocytes, all of them, and monocytes and neutrophils. Secondary hemostasis stabilizes the weak platelet plaque via the coagulation cascade. Coagulation cascade generates thrombin, which converts fibrinogen in the platelet plaque to fibrin. Fibrin is the cross-linked, yielding a stable platelet fibrin thrombus. Factors of the coagulation cascade are produced by the liver in an inactive state. Activation requires exposure to an activating substance. Tissue thromboplastin activates factor 7, extrinsic pathway, proconvertin. Subendothelial collagen activates factor 12, intrinsic pathway, Hagemann factor. Phospholipid surface of the platelets, calcium, derives from platelet-dense granules, and all of them activating the coagulation cascade. On this scheme you can see intrinsic pathway and extrinsic pathway of coagulation cascade, and all of them leading to formation of the clot. And on this picture you can see numbers and names of these clotting factors. To sum up the process, what's going on during hemostasis: vessel is damaged, endothelium is damaged, many signals and receptors activated, platelets attracted. Platelets come to a place of the damage and trying to glue the holes. Platelet plaque alone not stable. Many signals and regulators activated. Prothrombin activate thrombin, which activate fibrinogen, which turns into fibrin. Fibrin form strands. Fibrin strands comes and make primary platelet plaque stronger and more stable form a mesh. All these enhancers, helpers, receptors that help hemostasis occurs are called coagulation factors that taking part in the coagulation cascade, and each of them has its own number. Coagulation pathway can be divided for intrinsic pathway, which initiated by injury in the vascular endothelium, and extrinsic pathway initiated by external injury. Disorders of secondary hemostasis. Lack or absence of coagulation factors. Clinical features: deep tissue bleeding into muscles and joints, and rebleeding after surgical procedures. Laboratory studies, we're looking for prothrombin time. It measures extrinsic factors 7 and common factors 2, 5, 10, and fibrinogen pathways of the coagulation cascade. Partial thromboplastin time measures intrinsic factors 12, 11, 9, 8, and common factors 2, 5, 10, and fibrinogen pathways of the coagulation cascade. On this picture of the patient, you can see hemarthrosis. On this hem, you can see two systems. It's extrinsic system and intrinsic system of the secondary hemostasis. If extrinsic system is impaired, then prothrombin time will be increased, and if something happened with intrinsic system, then partial thromboplastin time will be increased. Also, you can see over here the numbers, and for example, if you see that the patient have deficiency of the AIDS factor, which is a part of the intrinsic system, then Hemophilia A occurs, and if present deficiency of factor 9, then Hemophilia B occurs. Let's talk about our first pathologies of the secondary hemostasis. I will be talking about hemophilias. Hemophilia A is also called classic hemophilia. It's more slight disorder than Hemophilia B, and Hemophilia B is also called a Christmas disease, and it's more severe. Both these disorders are X-linked recessive, predominantly affects males, increased partial thromboplastin time. Hemophilia A affected factor 8, it's deficient, mutated gene F8 on X chromosome, and Hemophilia B is characterized by deficiency of the factor 9 with mutated gene F9 on X chromosome. Both of these disorders characterized with inability to form fibrin clot adequately, delayed bleeding time, deep bleeds, spontaneous hemarthrosis. Treatment for the Hemophilia A is desmopressin, DDAVP, for mild Hemophilia A. Prophylaxis is factor 8 concentrate and tranexamic acid. Treatment for Hemophilia B is factor 9 concentrate and tranexamic acid. Also present Hemophilia C. It's a much rare disorder, a mild form of hemophilia. It's inherited differently than Hemophilia A or B. It's autosomal recessive way of inheritance, and as a result, it can be passed to both male and female children. Another pathology of the secondary hemostasis is von Willebrand disease. It's deficiency of the von Willebrand factor, regulator gene located at the chromosome 12. The inheritance can be divided for 3 types. The type 1 is autosomal dominant disorder, most common. More than 75% of patients with this disorder having exactly this type of inheritance. Type 2 is autosomal dominant and qualitative deficiency of this factor. Type 3 is autosomal recessive, is the most severe and rarest form of the condition, and also can be acquired von Willebrand syndrome. Is not caused by inherited gene mutations. Qualitative and quantitative defects of the von Willebrand factor can be found. Von Willebrand factor synthesized and stored in endothelial cells and megakaryocytes. When the vessel is injured, histamine and thrombin stimulate the local endothelial cell to produce von Willebrand factor. Then von Willebrand factor stick to the wall of the blood vessel and serve as a glue and attractant to the platelets, bind them. Platelet plaque is formed. Von Willebrand factor also carrying factor VIII and protects it from degradation. Clinical findings: mild mucosal and skin bleeding due to impaired platelet adhesion. Deep tissue joint and post-surgical bleeding are usually not seen. Laboratory findings: you can see increased bleeding time, increased PTT, decreased factor VIII half-time, abnormal ristocytine test. Ristocytine induced platelet agglutination by causing von Willebrand factor to bind platelet GP1B. Lack of von Willebrand factor, impaired agglutination, and it's causing to be abnormal test. Treatment is desmopressin, ADH analog, which increases von Willebrand factor release from viable pellet bodies of endothelial cells. Another pathology is coagulation factor inhibitor. Acquired antibody against a coagulation factor resulting in impaired factor function. Anti-factor VIII is most common. Clinical and laboratory findings are similar to Hemophilia A. Treatment of clotting factor inhibitors is platelet transfusion, fibrinogen, von Willebrand factor, factor IX replacement, cryoprecipitate, clotting factor concentrates, plasmapheresis, and others. Vitamin K deficiency disrupts function of multiple coagulation factors. Vitamin K is activated by epoxide reductase in the liver. Most often occurs in newborns due to lack of GA colonization by bacteria that normally synthesize vitamin K. Vitamin K injections is given prophylactically to all newborns at birth to prevent hemorrhagic disease of the newborn. Long-term antibiotic therapy disrupts vitamin K producing bacteria in the GA tract. Malabsorption leads to deficiency of fat-soluble vitamins, including vitamin K. Other disorders of hemostasis. They are heparin-induced thrombocytopenia, disorders of fibrinolysis, and disseminated intravascular coagulation. Heparin-induced thrombocytopenia, platelet destruction that arises secondary to heparin therapy. Fragments of destroyed platelets may activate remaining platelets, leading to thrombosis. Disorders of fibrinolysis. Normally, fibrinolysis removes a thrombus after damaged vessel heals. Tissue plasminogen activator converts plasminogen to plasmin. Plasmin cleaves fibrin and serum fibrinogen, destroys coagulation factors, and blocks platelet aggregation. Alpha-2 antiplasmin inactivates plasmin. Disorders of fibrinolysis are due to plasmin overactivity, resulting in excessive cleavage of serum fibrinogen. Examples: radical prostatectomy, release of urokinase activates plasmin. Cirrhosis of liver, reduced production of alpha-2 antiplasmin. Presence with increased bleeding. Labs. Laboratory findings. It will be increased PT and PTT. Plasmin destroys coagulation factors. That's why it will be increased. Increased bleeding time with normal platelet count. Increased fibrinogen split products without D-dimers. D-dimers not formed because fibrin thrombi are absent. Treatment: aminocapronic acid which blocks activation of plasminogen. And on the following slide, we will be watching the video about disseminated intravascular coagulation.
Disseminated intravascular coagulation, or DIC, describes a situation in which the process of hemostasis, which is when, after blood vessel wall injury, liquid blood rapidly becomes a gel, called coagulation, or clotting, starts to run out of control. When this happens, lots and lots of blood clots start to form in blood vessels serving various organs, leading to organ ischemia. DIC, though, is also called consumption coagulopathy, because all this clotting consumes platelets and clotting factors. Without enough platelets circulating in the blood, other parts of the body start to bleed, with even the slightest damage to the blood vessel walls. So paradoxically, patients have too much and too little clotting. Normally, after a cut and damage to the endothelium, or the inner lining of blood vessel walls, there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated, and then recruit additional platelets to form a plug. The formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood, there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. This cascade has a huge degree of amplification and takes only a few minutes from injury to clot formation. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to fibrin reinforcement of the platelet plug make up the process called secondary hemostasis and results in a hard clot at the site of the injury. Now, as soon as that clot's formed, the body's also initiating pathways to break down the clot so that it doesn't get bigger than it needs to be and dissolves when it's not needed anymore, a process called fibrinolysis. And this process produces fibrin degradation products. Normally, the formation of new clots and the process of fibrinolysis are in a steady balance. Now, in serious medical conditions, like for example sepsis, malignancy, serious trauma, obstetric complications, or intravascular hemolysis, like you might see with blood type incompatibility, there can be a release of a procoagulant that tips the scales in favor of clot formation. Procoagulants could be proteins, like tissue factor, or bacterial components, like lipopolysaccharide. Or it could even be the presence of enzymes that help to proteolytically cleave and activate clotting factors. Whatever the cause is, in response, the coagulation pathway goes into overdrive, resulting in widespread clot formation, which plugs up medium and small blood vessels, which leads to ischemia, necrosis, and eventually organ damage. The kidneys, liver, lungs, and brain are particularly susceptible. The massive formation of clots throughout the body depletes the supply of platelets and clotting factors. To make things worse, as those clots are broken down through fibrinolysis, fibrin degradation products are released into the circulation, and these interfere with platelet aggregation and clot formation, making hemostasis even more difficult. And the result is this paradox, right? On one side, you have thrombosis, which is when clots obstruct the vessel, and at the same time, you have trouble forming new clots, which leads to bleeding. Laboratory findings in disseminated intravascular coagulation include decreased platelets and decreased fibrinogen. There's also a prolonged prothrombin time, or PT, as well as prolonged partial thromboplastin time, or PTT, both of which reflect having lower levels of circulating coagulation factors. In addition to lower levels of specific clotting factors, there are elevated levels of D-dimer, which is a fibrin degradation product that's produced when fibrin clots are broken down. Now, it's worth mentioning that in some cases, disseminated intravascular coagulation can be a more chronic process, like in individuals with certain solid tumors and large aortic aneurysms. And in those situations, there might be physiologic compensation, which makes the lab results look relatively normal. In either acute or chronic DIC, the treatment focuses on treating the underlying cause, because that's what drives the activation of the coagulation cascade. In addition, the goals are to support the various organs using measures like ventilator support, hemodynamic support, and transfusions if they're needed. Alright, as a quick recap, DIC happens when the balance between forming new clots and breaking down clots is tipped in favor of clots, which leads to widespread clotting and organ ischemia, while at the same time depletes clotting factors, paradoxically leading to bleeding. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Thank you for watching and see you at our following lectures.